Exactly 1 year ago, we finished the second international consensus meeting on periprosthetic infections, joint infections, and so I'm going to talk a little bit what happened, how we organized it, why we organized it, and it's probably quite interesting for you. As we all know, the PGI, of course, is the worst complication in total joint arthroplasty. Sometimes it's going to be life-threatening. We really fight for the life of some of our patients, bring them to the OR several times. Sometimes we lose the leg, and so on. So, regarding the PGI, there are many facts. Fact one is, of course, infection is a terrible problem, and infection can kill. So we are doing about 500 cases a year in Hamburg, infected cases, mainly in the one-stage procedure. I'm coming later back on it. But of course, 1 or 2 of our patients per year are dying. Why? Because the survival rate is quite weak and quite low, because the PGI is sometimes worse than some cancers. This is a graph from Philadelphia, from Jay's group, who reported that the PGI is worse than, for example, breast cancer, melanoma, Hodgkin's lymphoma, or testis cancer regarding the 5-year survivorship. Another fact is the infection is on the rise. The burden of infection is increasing in every country. And this is a paper from Kurtz and Pavisi from 2012, where they estimated that in the year 2020 in the US they will face with more 65,000 periprosthetic infections per year. Another fact is, and this is very important, we have to prevent. We have to prepare our patients in a way that the infection risk is going down very well. So there are a lot of recommendations. The last recommendations about prevention came from the World Health Organization, and of course there are some other groups who give us some recommendations how we can prevent infection. So the WHO gave 2.5 years ago 29 recommendations about 23 topics. For example, and this is probably interesting for you, they recommend a single shot in perioperative antibiotic prophylaxis. Just 1 dose during the anesthesia, and that's enough. We are doing this since 30 or 35 years in our institution. Another a little bit sad fact is that antibiotics are not the holy grail. Antibiotics are not the solution. And the antimicrobial resistance is on the rise. We see more and more highly resistant germs, and that leads to the fact that in Europe and the US, 50,000 patients are dying because of infection and because there are no antibiotics available against the highly resistant germs. So we are running directly into a crisis. And we have to find some ways out of this, because each year in the US, at least 2 million people get an antibiotic resistant infection, and at least, again, 23,000 alone in the US die. And we see we can reach every month almost some news about super bugs, highly resistant germs. And then we try to find some alternatives to the antibiotics. A very interesting thing is this, for example, where they report about a 1,000-year-old antimicrobial remedy with anti-staphylococcal activities. So this eliminates the biofilm of Staph aureus. Probably we have to go back 1,000 years to find a solution. We have to use probably the nature to find nature by doing this here, because Staph luptonensis, for example, produce a substance, lactonine, that inhibits Staph aureus. So probably we can use one bacteria to fight against the other bacteria. And then, and this is another very important fact, musculoskeletal infections are difficult to diagnose. Why? Why they are so difficult to diagnose? Because of some tricks of the bacteria in our body. This is a very nice paper from Eddie Schwartz from the Mayo Clinic, who showed us that the Staphylococcus aureus, for example, is hidden in the little bone caniculi in case of a chronic osteomyelitis. And when they are sitting there, you cannot really diagnose the bacteria because they are hidden. Another fact is, and this is very important, and that led to the fact that we organized this consensus meeting, we don't have any evidence in all these topics about periprostatic joint infections, about diagnosis, about treatment, about hand prevention, and so on and so on. So Jay and I, we had a mission, and our mission was bring together expert doctors and scientists from around the world to determine the state of art related to orthopedic infections. Because the literature is not definitive on many issues. Much of what we have, and we can cite papers and papers and papers, in reality is based on thin science, if any at all. So, what is the challenge to generate evidence? Everybody wants to have evidence, but there is almost no evidence, especially in our field. We are talking since 2 years about many things, and behind the majority of the things we were talking, there is no evidence. Just a little bit religion, belief, gut feeling, and so on and so on. So our problem is to create some kind of evidence, is to do studies on infection. There's a really large sample size needed, about up to 36,000 numbers of patients. And not everything what we do needs really randomized prospective studies. I'm not the guy who wants evidence in every case, because if we look back in the history of medicine, when all these guys introduced, for example, here hand washing with sterile techniques, there was no evidence behind it. Or taking blood during the surgery, or antibiotics. When they designed the penicillin, or when they found the penicillin, there were no antibiotics available in the whole world, and there was no evidence behind it. So we are thinking more about, and we are believing more in equipos. Equipos means that opinion of the majority of the experts should be our way how we do something. So this was the reason why we organized the first international consensus in 2013, which was only about periprostatic infections. Last year we did this consensus much bigger, because we wanted to include all kinds of orthopedic traumatologic infections in every subspecialty. So the consensus meeting in 2018 was much bigger. You see the comparison between 2013 and 2018. We had about almost 900 delegates from almost 100 countries. Over 200 societies were involved, with almost 100 presidents of the societies. And the preparation on this meeting was mainly done in Philadelphia because J. Pabisi has a huge group of fellows, about 50, 60, sometimes 80 fellows who are working for him. And they came all to his house every week, twice or sometimes 3 times. I was always on Skype, and we discussed a different topic. We did it as a Delphi method. What is Delphi? You know you've all heard about the oracle in Greece, in the antique Delphi. Delphi method means to aggregate opinion, engage experts. A physical meeting is in the basic Delphi process not really needed. But we wanted a physical meeting because that's much more intense. And then we created a lot of subspecialties: general, Lebanese, shoulder, spine, trauma, foot and ankle, oncology, sports, biopharma. To cover really, pediatrics here also. All kinds of infections. So it was a journey over 2 years. We started with the preparation of the meeting 2018 in 2016. First step was selection of the delegates. What is an expert? Who is an expert? Nobody knows. So we decided to say an expert is a guy who published at least 5 papers about one topic in 5 years. Or he is nominated by his society. So I'm traveling a lot, Jay is also traveling a lot. In every country we ask the president of the society, who is the main or the most important or the expert in this field in your country. Clinical care, basic science research are also making an expert. Step 2 was collection of questions. So we asked every delegate, every expert to send us 5 to 10 questions. What are interesting for him. So we received about 3,200 questions, and then we did a ranking of the questions. Some questions were removed because of the duplications, and we put it down to 650 questions. Then we started with a systematic review regarding these 650 questions. And during this systematic review, in the preparation area time, over 200,000 publications were reviewed. Then we went for a face-to-face meeting. We discussed some controversial questions, very intense. We did it in Philadelphia at the Jefferson University last year. The attendance were about 600, more than 600 experts from all over the world, from almost 100 countries. Very intense discussions, 3 days. It was really exhausting. And sometimes then every delegate voted about our recommendations that we found out or that we created during the preparation process. And I will give you just some examples. Prevention. Obesity. That was a patient of mine. Maria, 75 years old. You see post-traumatic osteoarthritis of the hip. She received an ORF before, and she had some comorbidities. One comorbidity was obesity. So obesity in many countries is a huge problem. Obviously in Ecuador it's not such a big problem. Patients I operated here were quite normal. And in the US it's of course different. So always simple questions. What upper body mass index threshold is associated with an increased risk of SSI-PGI, and does implementation of these cutoffs reduce the incidence of SSI-PGI? Has anybody of you a personal cutoff? Esteban, what is your cutoff?
40.
40. Bill?
I do not have a cutoff, which is a problem.
Whoa.
I don't have a cutoff, but at 40, we try to see whether we can kind of optimize that as best as we possibly can. Yeah.
So, but you see, nobody is really sure. At 40, we think about to do something. So we reviewed the literature, and there were two recent studies of approximately 20,000 patients. And both studies showed the risk became progressively more pronounced for the group of patients with BMI value above 40. So, and all the other publications we reviewed said the same thing. So we came up with a recommendation of obesity increases, of course, the risk of SSI-PGI, and a substantially increased risk is noticed in patients with a BMI over 40. So, and then we asked the delegates to vote, and every delegate could vote agree or disagree with this recommendation or abstain. And here, cutoff of 40 or to think about something about 40 was, the agreement was 95%. Very, very strong consensus. And if you talk about obesity and total hip replacement, for example, everybody of us see that this is really not always a home run. Sometimes we run into really, really severe complications. They have a long operation time. Interestingly, the literature shows no difference in the prompts. But, and this is one of the best papers coming from the Mayo Clinic and Barry's group, they showed that from all revision surgeries increased from BMI 40, and regarding infections, it increased from BMI 40 really dramatically. So if you have a patient about 40, you have to think about to do something to set him on diet or to send him to bariatric surgery, something like this. Because obesity is many, many times comes together with metabolic syndrome, which includes 4 components: obesity, diabetes, hypertension, and dyslipidemia. This is the metabolic syndrome, and all of these diseases increase the risk of infection. So Maria, my patient, had a post-traumatic osteoarthritis, and the question was, does this increase the risk of SSI-PGI? Who thinks that it increases the risk of SSI-PGI of infection? Majority, yes, of course. Yeah, let me think about it. But do you know some literature about it? No, I didn't know. So here are the experts, Neil Chance from Japan, and our friend Saleh from Egypt. They worked on this question: is the diagnosis of post-traumatic arthritis associated with an increased risk of SSI-PGI? Literature: 1 systemic review, 1 prospective, and 6 retrospective. And of course, yes, total joint arthroplasty was a recommendation. It is, with post-traumatic arthritis, are on a higher risk for developing SSI-PGI. This was also very high consensus, 97%. Diagnosis is very important. Probably the most important step in the whole procedure. And here's a patient from Jake Parvisi from Philadelphia, Etho, 82 years. She got a total knee arthroplasty due to osteoarthritis. Long operation time, almost 2 hours, because they used a robot. Robot is another topic. We didn't cover it, fortunately, here because I had extensive comorbidities, multiple prior knee operations. So after the surgery, she had some complaints, knee pain, instability to weight bear, but locally no signs of infection, clinically no fever, chills, or night sweat. So she underwent revision for aseptic loosening because of the pain, They changed the tibial component, and then after a while she had a fall, she couldn't straight leg raise, the wound healed, but again no signs of infection. And the parameters were ESR 30, CRP 12, and D-dimer 990. So, do you think she's not infected or not? Nobody knows. And this is very important. The question was, does the presence of both an ESR and CRP below the PGI threshold rule out the infection? So it means if you have a normal CRP, does it really rule out the infection? Quite a lot of literature behind it, and we came to the recommendation that ESR and CRP levels below the threshold does not exclude the diagnosis of periprostatic joint infection. Not exclude. And here we had a consensus of 100%. We had only 2 or 3 questions where we got 100% consensus. This was one of them. So if you have a patient with a normal CRP level, you can never be sure that he is not infected. That is the reason why we are performing aspiration in every patient who is undergoing a revision. And I strongly recommend it to you. We have an app of the consensus meeting, I showed it now to you, where we have the infection risk, and we have include all the time a paper of the week. The paper of the week this week is a paper where they look up the revisions, 390 revisions, something like this, during the last years. 15% of the aseptic revisions they did were in reality septic revisions. 15%. So that's my personal recommendation. Please exclude always an infection by aspirates in every patient you are undergoing. Even a patient who is dislocated, even a patient who has a fracture, and so on and so on. Read this paper. So because of the time, I like to give you only one advice. I'm going down. Because for me the most important result of the consensus meeting, so the consensus meeting, by the way, is now translated in many languages. We have the Spanish translation done by a big group of Spanish and South American surgeons. We have a Ukrainian translation, we have a Japanese translation, we have the Chinese translation in the meantime, the Polish translation, Korean, and so on and so on. But for me, my only take-home message is, please download this app to your phone, the ICM Philly app. Just give in, go on the App Store, ICM Philly is the name of the app. And I'd like to introduce you to this app shortly. This app includes the entire document, every question, every recommendation. You can use everything. And we put it all in a presentation with this design that you can see here. You can use it for your talks, for your presentations. It's free. Then we have, every week, I told you, one paper, the paper of the week. And then we have the PGI risk calculator. This is quite interesting because we calculate the risk of our patients. Let's come back to Maria. You can give in this calculator all the data of your patients. Here you see Maria again. You can put in all the comorbidities via BMI, diabetes mellitus, poor tooth status, and so on and so on. And then you put in the age of the patient, how he's insured, everything. And then you come up with an estimated lifetime risk of PGI. And Maria had an estimated lifetime risk of about 6% to develop the PGI. We have includes diagnostical tool, our new diagnostical consensus recommendation. where we included D-dimer, alpha-defensine, and leukocyte esterase. And we made some points. So every patient who reaches more than 6 or more points is infected in our opinion. And we just controlled it, and we have seen that the sensitivity is about 97%. We have all the articles in this app, so please load down the app, and then you can look always after these things. Thank you very much.